All right. Evening, everyone. Today, our group is doing a presentation on Dell Children's at Home. And this is basically going to be the outline of our presentation. We're going to discuss the introduction to pediatric hospice care and the services that Dell provides. Also looking into eligibility and the demographics that they serve, and looking into the interventions and how they support families. And then we're going to be going into the literature review, and then theoretical framework. And if we have time, there is a brief 5-minute video on losing a child. So Dell's Children at Home is located in the medical center, Central Texas in Austin. Their program is a palliative care program. The hospital benefit provides coverage for medications, supplies, equipment that are needed to support pain and symptom management of the terminal illness.
Some differences, I got it.
Sorry.
Between the pediatric hospice versus the geriatric hospice, effective August 1st, 2010, a family electing to receive hospice care for an individual under the age of 21 is no longer required to waive treatment for the terminal illness. Also, concurrent services now allowed include services related to the individual's terminal illness and hospice care, including palliative care, which is medical and support services related to the individual's terminal illness. Next slide, please. Some eligibility requirements for Dell's children. Patients must have a diagnosis of a life-limiting illness or terminal disease with a life expectancy of 6 months or less. They also need to live within a 50-mile radius of the hospital. There is not an age requirement as long as the patient has been connected within the Dell hospital system. And they accept patients with or without insurance as a part of the Ascension Settings commitment to care for all people, regardless of their ability to pay, with special attention to those who are poor and vulnerable. Next slide. Some demographics and the populations that are served. These patients are typically medically complex and rely on medical technology to live. So we're talking about things such as feeding tubes, respiratory support, such as like a breathing machine. Some families are still interested in treating reversible illnesses, and some then opt for intensive, treatment interventions. They can provide support to families, whether or not these families choose to use this type of medical support. And they do not require that the patient is on a DNR, which is a do not resuscitate order. Next.
All right, so about a little bit about the at-home team of Dell Children. So it's a fairly new program. They've had a palliative program, and this was under works for about 2 years, and they finally got it up and running in this year in April. So it includes hospice, medical directors, physicians, and nurse practitioners. Right now they have one medical director and one physician, and then one nurse practitioner. They're really responsible for medication and treatment management. They also are responsible for doing reviewing patients' continued eligibility for hospice services. Hospice nurses really are the point of contact within this program. You are assigned one hospice nurse as your point of contact, and she visits you. She's the one who does the visits routinely, routine assessments, caregiver education, aggressive symptom management at the end of life. They're also there to support the family in the decision-making process and coordinate with the other team members. The hospice nurses right now that they have there are 2 nurses and then a case manager. So Dell Children's at-home psychosocial team. It is combined with 2 social workers, a child life specialist, and chaplains. They also have hospice aides and then volunteers for bereavement counseling. And really this team the role is to support the family by ensuring healthy coping. The chaplain there is there is no religious affiliation. They are there to support the family in spiritual counseling, to support and get the families connected to groups, connect families with practical resources for needs, whether it be like groceries or utility funding. But all 3 of these would be responsible for that. The social workers, they provide a space for emotional support. They help with making final arrangements and also provide education to parents and families about anticipatory grief and ambiguous grief. The child life specialist, her main role there is really legacy work and memory making, but they also are there for the parents, and they all provide sibling support and education. So the next slides are really, they're based off of the interview that was conducted with the Dell Children's, pretty much the psychosocial team, and specifically the social worker. So I had the pleasure of speaking with their social worker, Rachel Carnahan-Metzger. She is actually somebody that I personally know and have known for about 5 years. She joined the palliative care team over at Dell in January 2012. She has a master's and did her palliative care training in Sydney, Australia. She is the supervisor or field supervisor for social work students at UT and Baylor University, and she also volunteers at the Austin's Grief Counseling Center. So really the settings that this team, this at-home hospice team works in is wherever the family's at per Rachel and the other team members. What they do is they really just meet them in whatever setting that they're at, whether it be where they're home, where they're visiting, as long as it's within the 50-mile radius of Dell. They will go to clinic visits with families to provide support. And also they will see patients in the hospital if they've been admitted. So meaning making, this is one of the interventions that I've seen for families that somewhere along the line has been helpful in their bereavement process. These are just for the ones in Austin. Penny Pals was started from a family, or by a family that lost their daughter. And what they do is they go out to families that are on hospice and really just provide opportunities for special moments and memories. Like on Easter, they had the Easter Bunny come out and see, kiddos and provided Easter baskets and gift cards. And then you have the Abigail Keller Foundation, and that's from another family member that lost their child. And they actually started fundraising and provided funding for the child life specialist position, but they also provide funding for the hospice team and the comprehensive care clinic. So the Hope Support Group is a part of the Ronald McDonald organization, and that's for mothers that have lost their infant or their unborn child. So it is a huge, I feel like this is one intervention that you see a lot of the families that are on pediatric hospice really get involved with and see what they've done for the families after, and trying to make meaning of, what's happened. Next slide. So the challenges and the issues faced with this population. Rachel explained that it's a unique population because they are at high risk for complicated grief because the loss of a child is profound. However, oftentimes, a lot of these referrals to hospice are coming from their palliative team, which sees terminal, they have a lot of patients with terminal diseases, but don't have, are not expected to die within 6 months. So complicated grief is something that they see as an issue, along with anticipatory grief and ambiguous loss. They have a bereavement process that continues 13 months after the child dies. And kind of how that's assessed is they've developed their own bereavement assessment specifically for families in pediatrics. So the initial assessment, it's completed at the time of intake. And then the final one is completed after the child has passed. And it's really to determine if the family is low or high risk for complicated grief. And depending on the score, that determines the amount of visits that take place. So for low risk, it's 9 visits, and high risk, it's 13 visits. And these are then scheduled on a regular basis. So next slide. Okay, so interventions used in practice to address grief issues. So this is interesting because speaking from personal experience with this, and I've seen it, but hearing them say it is it was a very interesting, informative to hear them talk about it. Each of the members of the team, the nurse included, said that the psychoeducational approach has been very effective in helping families better understand ambiguous loss. Another intervention is the validation of caregivers' experience and normalizing what they're going through. And she said that many times their families, have this experience of grieving for someone who's right there. They feel uncomfortable and uncertain about those things, and a lot of times don't really recognize some of the symptoms that they're having. So really offering that space for emotional support by validating what they're experiencing is something that they do often. They also, and part of the psychoeducational approach, they have handouts, they'll give books. And so I put a few links on here that really kind of just put it in layman's terms for families and offer some sound information to kind of help them understand what they're processing. This on you, Cynthia.
Okay, so the first journal article we looked at was called Anticipatory Mourning in Parents with a Child Who Dies While Hospitalized. The purpose was to examine the existence and absence of anticipatory grief and the role that it had concerning the parents who recently dealt with the death of a hospitalized child. The researchers of that particular study were looking for consistent factors in the parents who experienced anticipatory mourning and that they found to be either helpful or harmful. So from that study, they found 6 major themes that were noticed, and each of the 6 themes are noted there at the bottom of the slide. And each of these themes either had a positive or a negative effect on the bereavement process, depending on the experience of the bereaved parents. This study also found that giving sufficient information helps parents to begin the process about what is happening and to kind of come to terms with the present situation as well as what is to come later. Also, it found that the need for healthcare members to operate in a role of like a coach, assisting them and describing what's going on and guiding the parents through what is involved in and anticipated in the dying process. So that was something else that was noticed. Also, the parents' ability to physically be present and contribute to their child's care leading up to and following their death, as well as them being able to have like a comfortable place and atmosphere to be in, giving them the freedom to grieve and to complete whatever tasks they feel are important while their child is dying, was also found to be an important factor with, dealing with the anticipatory mourning. Next slide. With the second journal article, it was called The Impact of Losing a Child on the Clinical Presentation of Complicated Grief. And so the purpose of this study was to determine whether or not bereaved parents with complicated grief struggled with their grief differently than others who were experiencing complicated grief. So we're talking about, people who weren't parents. This study found that parents with complicated grief, they actually showed slightly higher levels of complicated grief. And they also described having more intense, caregiver self-blame and suicidality than those who were not parents, but experiencing complicated grief. Also, parents who lost younger children were more likely to wish that they were dead themselves than those who lost older children. There were elevated levels of suicidal ideations by the parents with complicated grief, more so after they lost a younger child. So this pretty much showed how important it is to routinely screen for suicidal thoughts, especially, with this particular group of individuals. The study also concluded that the relationship between the deceased may be influenced by the degree of the relationship they had. So the more close they were, the more bonded they were, they typically had more severe grief symptoms and, more intense other feelings. Next up, Miss Yolanda.
So the collaborative team at the Dell Children at Home, they meet together and they work together to meet the physical, emotional, social, and spiritual needs of the patients and families. They have a care plan, action takers that routinely update with other members of the team, and their psychosocial team assesses the non-medical and spiritual support to patients and families, including coping skills, funeral planning, spiritual support, and emotional support. They also do referral to professional counselors and support groups. And on the other side of our slide, we have the guidelines, intervention guidelines, acknowledgement of parenthood, giving parents privacy in the moments through the process from, before the loss and after the loss, and giving them, privacy during that time. And also helping parents identify and experience the feelings and share on the loss of their child by talking about their emotions and just kind of walking through their grief. And as Maggie mentioned, the meaning making, which parents examine different themes and helping make sense and, of the loss. And then providing psychoeducation, informing parents of finality of options by sharing information, including like protocols for bereavement care prior, during, and after the loss. And implications of social work practice, they support system, counseling services, community support, group support, and also following up, doing assessments, making sure that the family's needs are met, and also have empathy. And I don't think we have enough time for this, but there's 2 videos that talk about loss. And one of them is a 5-minute video. This one is by Dr. Stephen Libben. He's a palliative care pediatrician. And in this video, he talks about how parents should.
You can go ahead and show it if you want. I think we have enough time.
Okay. All right. I'm going to click on it, see if it'll play for me.
is Stephen Levin. I'm a palliative care physician, pediatrician. I work in Montreal. How did I get into this field? Probably the way most people get into most things. I stumbled into it, I guess, and but it was a good stumble, sort of a planned stumble. So I was trained as a pediatrician. I worked in the hospitals. I trained in pediatric intensive care. So I was an intensive care doctor for like a decade. And I found that I was being drawn more and more to families that had very seriously ill kids, which also defines the children in pediatric intensive care. But that what I was in, I don't know if it was joy there were, what I felt was meaningful rather than enjoyable was working with families where the kids were living for a long time and not just coming in and out of the ICU. So I was drawn sort of to palliative care work. And when there was an opening, I sort of made my way into it and it turned out to be a good fit 18 years later. I don't really know. And I guess what I see is I don't see people so much afterwards. What I see them is during. I see people who seem to suffer a lot more during. Everybody suffers. They all suffer, but it's how much. Sometimes it's like unbearable. It's the extra suffering. So for example, not for example, but I think the crux of it is allowing what is to be as it is. So what does that mean? Because acceptance is even a level further. So when your kid's really sick or something really terrible is happening, we sort of have a choice, even though it doesn't feel like a choice. Like you can say, this isn't happening, I refuse to accept this. You know, my child's gonna get better and that's the end of it. So the families that do that, and that's a coping mechanism, if their kid isn't gonna get better, there can be a lot of extra suffering along the way as they go through a lot of pain for procedures and other stuff that isn't gonna work. Even though some of it may be reasonable to try, some of it isn't. And it's particularly holding on to the fact that this is unacceptable. So to give an everyday example that I think is easy to relate to, you know, if you're getting married one day, maybe you'll get married one day. And it's raining that day, the wedding, you know, it's pouring and you had an outdoor wedding planned and everything else. Well, there's actually a couple of choices in there of what you're going to do about it. You can go, oh my God, it's raining. This is terrible. This is awful. This is horrible. Oh, it can't rain. It can't rain. And you can carry on like that and you can be really upset and you can maybe feel sad and angry and all those things and go through the day like that. Or you could say, well, it's raining. Didn't want it to rain, but it's raining. Whether I wanted to or not, this is what's happening. What am I going to do with this? How am I going to be with this? If you can sort of allow it to be as it is, because you can't change it, but you can allow your reaction to change. You can't change your reaction to it. So you can sort of say, well, I can see that I don't like this, but it's not really going to be helpful. So I just allow it to be as it is and not keep saying it shouldn't be there. It's going to be there no matter what I say. It is raining. Maybe there'd be some potential to enjoy the wedding day anyway. People enjoyed wedding days in the rain. I think so. People have great weddings in the rain. So I'm not saying that having your child be really sick is as mild as raining out. But what's similar is that there's some things that are unchangeable. Like if your kid's really sick and has a terminal illness, and there's really nothing left in terms of hope for cure, there is for other things besides cure. That's what people find when they let go of resisting what's unchangeable. So if you let go of the fact that it's raining and say, well, what are the things that I can do on this day that's good? You might have a fun wedding day in the rain, possible, or maybe really meaningful. If your kid's really sick and you say, well, he's really sick, there's some of that I can't change. I hate it to my core, but I can't change it. But you say, what can I do? Well, I have this moment. I have this time. Can I connect with them the best I can? Instead of using all my energy, taking it off that and putting it on fighting something that's unfightable. So that's the difference that I see is just dropping the resistance to what's happening and instead working with whatever there is.
Okay. The second video that I posted here is called Helping Parents Grieve, Finding New Life After the Death of a Child. This video is about an hour long. I found it in while researching videos. I was on the U of H library. It's from alexanderstreet.com. And this video documents parents grieving through various losses at different stages, and it's a very interesting video. I watched the whole thing, and it was very interesting watching these parents go through the process of their grief. It was very heart-wrenching too, because I just you know, couldn't imagine the pain that they were feeling. But you know, it's a in-depth video of that. So if anybody wants to watch it, the link is there. If y'all want.
If you could post these links as well as the links that were earlier in your presentation, and maybe start a new thread. There's like an open forum on Blackboard. You can start a thread and just put those links in there, because I would like to review some of them too. Especially the podcast and some of the other things on that other slide. So that would be really helpful for all of us. So thank you.
And I think that's it. Yeah, references.
Thank you very much. Thank you very much. That was very detailed, and you know, I did hospice, and I know that it's different. Children's hospice. I only ever had one pediatric patient, and it's very labor intensive, very emotional intensive, and it's you know, but it was one of the most meaningful things I've ever done as a social worker. So so thank you, all of you, for your presentation.